Tara Reberger, and I will be your nurse practitioner today. I understand that you've come in for some left shoulder pain, so I'd like to talk to you about doing a shoulder injection of a steroid. Before we do that, I will need to obtain informed consent. So I'd like to go over the benefits of that procedure, which include decreasing the pain and inflammation surrounding the joint, helping with range of motion, and preserving joint function. Risks of the procedure include tendon rupture, joint infection, a post-injection flare related to the steroid, injection to a blood vessel, tissue atrophy or wasting, allergic reaction, nerve injury, or just that the joint injection itself is unsuccessful and it doesn't take. These risks can all be minimized with proper procedure. And then other things that we need to talk about before we get consent would be contraindications to the procedure itself. So an infection of the joint or cellulitis over the joint is a contraindication, as well as more than 3 injections in a 12-month period, joint instability or fracture, joint surgery or prosthesis. Other medical conditions that warrant special attention include sickle cell anemia, coagulation disorders, or uncontrolled coagulation therapy that increases the risk for bleeding, diabetes, or children and adolescents. So before we get informed consent, I would like to ask you, do you have any questions regarding any of the information that we just went over?
No, no questions.
Okay, so do you consent both verbally and written to have this procedure done today, the joint injection into your shoulder?
Yes.
And which shoulder will we be doing the injection on today?
The left shoulder.
The left shoulder. Okay, great. So the next part of the exam will be the physical assessment. So I'd just like to start out by looking at the shoulder. As I mentioned, contraindications to the procedure include infection or cellulitis over the joint. So in looking at the shoulder, it is not warm to the touch. It is not red with profuse swelling, no drainage or foul odor that would represent, signs of infection or cellulitis. So those would not be contraindications to the procedure today. While we're here, I would like to identify the landmarks that we use for the joint injection. So feeling here for this prominent process is the acromion process, the head of the humerus, and then the coracoid process, which is the major landmark for this procedure when we use the anterior approach. Okay, so for the next part, we'll do an assessment of your range of motion. We'll compare both sides bilaterally, and I will ask you if you have any pain, and we will note any decreased range of motion to the affected side. So we'll start out by having you raise your arms up, and this represents shoulder flexion, and back behind you is shoulder extension. Arms away from the body is abduction. Reaching the opposite arm across is adduction. And again, the other side. External rotation, so taking your arms like this, taking palms up. Internal rotation by reaching for your bra strap. And again, overall rotation. And I'd like to ask you, did you have any pain when we were doing any of those range of motion exercises?
I did have some pain right here, right in the front of my shoulder there.
Okay, we did note some slight decreased range of motion with those exercises, and our hope would be that with the procedure we can minimize that pain and help you preserve the joint function. Another test I want to do is the drop test, which tests for a rotator cuff injury. So to do that, I will have you passively lift your arm out, and if you can, hold it there, and then slowly start to lower the arm down. A positive drop test would be an inability to hold the arm out, it just drops to the side, or you have immense pain and you can't slowly lower it to the ground, which I did not note those findings on your exam. So we will now talk about the supplies that we will use for this procedure itself. We have gloves. If we were going to anticipate an aspiration for possible culture and sensitivity, we'd want sterile gloves. These are clean gloves, as we didn't note diffuse or profuse swelling of the shoulder. We will use alcohol or proviodine preparation. We have a Band-Aid for after the procedure itself. We have a 2 to 3 ml syringe with a current 18 gauge needle that we'll use to draw up our solution, which is the 1% lidocaine without epinephrine. We'll draw up approximately 1 milliliter of this. Okay. Oh. And then we have 20 to 40 milligrams of methylprednisone acetate. Drop that, which gives us a total of approximately 2 to 3 mLs that we will inject into the joint space. We will need to switch the needle out to a 27 gauge 1.5-inch needle for the actual injection. I'm going to go ahead and apply my gloves here. For the anterior approach, we will go ahead and have you externally rotate. And I'm just going to feel again for my landmarks here. Okay, and we're using the alcohol or proviodine solution to clean the area. And again, can you verify that this is the correct site?
Yes, my left shoulder, that's where it hurts.
Okay, perfect. So we will give that time to dry. And again, we have our solution mixture, which is the 1% lidocaine without epinephrine and the 20 to 40 milligrams of methylprednisone acetate that we have rolled in between our fingers to make sure it's properly mixed. Okay, and as you know, I marked my site. Alright, so for the coracoid process, we will go inferior and lateral to this particular landmark, aiming laterally into the joint space. As I mentioned, we have the arm externally rotated to open up that joint space. And you see the green light here that we are in. It is important to aspirate back to make sure that we don't have any blood return, and I didn't feel any resistance or hit any bone, and no blood return in my syringe. So I will inject our steroid solution. Slowly, not meeting any resistance. Okay. Taking that out. And then putting the Band-Aid on, which will have you leave this Band-Aid on for the first 24 hours.
Okay.
Alright, so now we can talk about your follow-up care. So we would like you to rest the joint for the first 24 hours. That's very important. As I talked about, we'll have you remove the dressing within 24 hours. We want you to observe for signs and symptoms of infection, which would be increasing warmth, redness, increasing pain, swelling, drainage, foul odor, you have fever, chills. Those would all be indicative of a potential infection. We want you to call the office immediately. There's also the risk of the steroid flare or post-injection pain lasting greater than 36 hours. So techniques to help with that would be to ice for 20 minutes every 2 to 3 hours. You can do Motrin every 6 hours as needed for pain, and then call the office if the pain persists and does not get any better. For pain control in general, we'll have you use ibuprofen or Motrin every 6 hours anyway, as you need it. Have you been aspirating a large amount of fluid for culture and sensitivity? It takes 48 to 72 hours to get those results back. And then if for any reason you had a recollection of fluid, we would want you to call the office as well. As we talked about with contraindications, you cannot have more than 3 injections in a 12-month period, as it is contraindicated due to the risks and benefits of the procedure. What questions do you have?
None, thank you.
Alrighty, so we'll follow up with you if everything goes well in a couple of weeks and see how you're doing.
All right, thank you.
Thank you.